55%. That's how many hospice claims get denied because the documentation doesn't support a 6-month prognosis. And if you're working with coma patients, you're in one of the highest risk categories for Medicare audits. Hi, I'm Dr. Brian Haas, the National Medical Director for Ascend Hospice, and I'm a board-certified hospice medical director. Today, we're diving deep into the 7 most common documentation pitfalls that trigger denials for hospice patients with coma. More importantly, how to avoid them before an auditor ever sees your charts. Whether you're a hospice nurse, physician, or compliance officer, the next few minutes could save your agency hundreds of thousands of dollars. Let's get started. In the current regulatory climate, healthcare providers, particularly hospice agencies, face an increasingly stringent audit environment. Medicare audits are not merely continuing, they are intensifying at an unprecedented rate. This surge is a direct result of the Center for Medicare and Medicaid Services, CMS, implementing more robust and focused oversight programs. Among these initiatives, 2 stand out as particularly impactful for hospice agencies. The Special Focus Program, or SFP. This program identifies hospices that consistently demonstrate a pattern of serious deficiencies or substandard care. Agencies placed under SFP scrutiny are subject to more frequent and intensive surveys with the potential for escalating enforcement actions, including payment suspensions, civil monetary penalties, and even termination from the Medicare program if significant improvements are not made. The SFP serves as a clear signal that CMS is committed to addressing persistent quality concerns within the hospice industry. Targeted probe and education audits. CMS has significantly increased the volume and scope of TPE audits for hospice agencies. TPE audits are designed to help providers reduce errors through education, but they also serve as a powerful tool for identifying and recouping improper payments. During a TPE audit, Medicare Administrative Contractors, or MACs, review a small sample of claims, identify errors, and then educate the provider on how to correct them. If errors persist after multiple rounds of education, the MAC can move to more serious actions, such as 100% prepayment review, extrapolation of overpayments, and referral to other enforcement entities. These enhanced oversight programs collectively demonstrate CMS's unwavering commitment to ensuring program integrity, preventing fraud, waste, and abuse, and ultimately safeguarding beneficiary care. For hospice agencies, this translates into a critical need for meticulous documentation, robust compliance programs, ongoing staff training, and proactive internal audit processes to navigate this heightened regulatory landscape successfully. The pressure on agencies to demonstrate medical necessity, proper billing, and adherence to all Medicare conditions of participation has never been greater. Here's what's really concerning. 18% of denials happen because physician narratives are missing or invalid. Another 9% fail due to election statement errors. But that 55%, that's pure documentation failure. And here's the thing. Most of these denials are completely preventable. They're not about fraud or trying to game the system. They're about busy clinicians who don't realize their documentation is missing critical LCD criteria. For hospice eligibility in coma patients, Medicare requires a 3-part assessment before considering disease-specific criteria. So first, patients must demonstrate a decline in clinical status. While the guidelines are broad, making them adaptable to various patient conditions, they also lack a minimum number of specific criteria that are required, which can be challenging. Clinicians should look for indicators such as recurrent infections, weight loss, worsening disease symptoms, changes in objective measures, i.e. low blood pressure, increased edema, and generalized weakness. Deteriorating lab values are also highly relevant. Second, there must be a documented increase in the patient's need for assistance with activities of daily living, or ADLs. And the palliative performance scale score should be recorded. Now, thirdly, clinicians must consider comorbidities. It is understood that a single condition rarely exists in isolation, and significant issues with one condition can intensify the severity of other existing problems. So, according to CGS guidelines, comatose patients are considered terminal when they have any 3 of these findings on day 3 of coma. abnormal brainstem response, absent verbal response, absent withdrawal response to pain, or a serum creatinine greater than 1.5. Now, notice that specificity. Day 3 of coma, not day 1, not several days ago, day 3. This temporal component is crucial, and it's where our first pitfall begins. You also need to document secondary conditions that are caused by the coma, like dysphagia, pressure ulcers, aspiration pneumonia, and other comorbid conditions that make the prognosis worse. Now, I have identified what I like to call the 7 deadly documentation pitfalls. Let's start with pitfall number 1, vague or generic descriptions. Now, I see this frequently, not just when documenting for coma, but for all disease-specific documentation. The nurse will often write, patient is unresponsive, or patient in coma, and then simply moves on. The problem? An auditor can't verify LCD criteria from that. They need specific neurological findings. So instead, they should probably document something like this. Patient is exhibiting no eye opening to verbal or painful stimuli. Absent corneal reflex noted bilaterally. No withdrawal response observed when nail bed pressure applied to all 4 extremities. So, do you see the difference? Every claim is measurable and subsequently verifiable. All right, moving on to pitfall 2, missing of the temporal documentation. The missing 3-day assessment. So remember, LCD criteria specifically require findings on day 3 of coma. So if your documentation says patient has been comatose since admission, but doesn't specify when day 3 occurred or what was assessed that day, you've created an audit vulnerability. So a better documentation might be something along the lines of, patient remains comatose since September 15th of 2025, which is day 8 of coma. Initial day 3 assessment on September 17th documented abnormal brainstem response, absent verbal response, and absent withdrawal to pain, all criteria maintained throughout admission. Now you've just given the auditor exactly what they needed to verify eligibility. All right, pitfall number 3, disconnected secondary conditions. Failing to connect secondary conditions to the primary diagnosis is a major problem. Your patient has a stage 3 pressure ulcer. Well, that supports terminal prognosis. But if you just document stage 3 sacral pressure ulcer present, you've missed the boat. You need to use causation language. I'm going to say that again. You need to use causation language. Stage 3 sacral pressure ulcer present, directly attributable to immobility secondary to patient's comatose state. Patient unable to reposition self due to absent voluntary motor response. Wound showing no signs of healing despite treatment protocol. So now you've shown the auditor that this isn't just a comorbid condition. It's a direct result of the terminal diagnosis that compounds the prognosis. Pitfall number 4, inadequate comorbidity assessment. Ignoring how comorbidities compound the terminal condition is a major concern as well. Your coma patient may also have COPD. That's relevant because it increases aspiration risk given their impaired cough reflex. Don't just list COPD in the diagnosis list. Document the interaction. The patient's underlying COPD with an FEV1 of 35% predicted significantly increases risk of aspiration pneumonia given the impaired cough reflex secondary to the comatose state. The patient experienced 2 episodes of pneumonia requiring antibiotics in the past 60 days. Now you're painting the complete clinical picture of why this patient has a 6-month or less prognosis. Pitfall number 5, unsupported functional status scores. Now, pitfall number 5 isn't just relevant to coma or, some other diagnosis. It's relevant to all of our diagnoses. Documenting a PPS or KPS score without narrative support. You may write a PPS of 10% and think that you're done, but an auditor is going to ask, what observations support that score? So you have to provide the evidence. PPS of 10%. Patient is completely bedbound, unable to perform any self-care, requires total assistance for all ADLs, including feeding via PEG tube, turning every 2 hours to prevent skin breakdown, and all personal care. Conscious level fluctuates, but patient remains nonverbal and non-responsive to commands. No purposeful movement is observed. Now, that PPS score is defensible because you've documented the clinical findings that justify it. Pitfall number 6, weak physician narratives. Pitfall number 6, this is a big one. 18% of denials trace back to this weak or missing physician certification narrative. So I've seen many physicians write, patient meets hospice criteria, or copy paste the exact same narrative from the previous certification. That is no longer going to fly. Physicians need to reference specific LCD criteria, discuss the clinical trajectory, and explain the reasoning. For example, patient meets LCD criteria for terminal coma with documented abnormal brainstem response, absent verbal response, and absent withdrawal to pain on day 3 assessment. Underlying hypoxic brain injury from cardiac arrest on September 15, 2025, despite 14 days post-event, patient shows no neurologic improvement on serial exams. Multiple comorbidities, including advanced COPD, recurrent aspiration pneumonia, significantly worsen the prognosis. Based on clinical presentation, comorbidity burden, and absence of neurological recovery, it is my clinical judgment that patient has a life expectancy of 6 months or less. Now, that narrative shows clinical judgment, references specific criteria, and documents the physician's thought process. That's what auditors need to see. Pitfall number 7 is what I call static documentation. When auditors see identical language week after week, they start to question whether you're actually assessing the patient or just copy and pasting notes. Now, each visit note needs to stand alone with updated clinical information, documenting changes, even subtle ones, new pressure areas, increased secretions, changes in breathing patterns, development of contractures. If the status is truly unchanged, say so explicitly. Comprehensive assessment is completed. The patient condition unchanged from previous assessment with persistent absent responses as documented above. Continues to meet the 3-day coma criteria. You've shown that you did the assessment and documented your clinical findings. Now, what we all need is a real-time solution. The challenge with all of these pitfalls is most agencies don't discover them until it's too late, until an auditor requests your records months or years after the service was provided. At that point, you can't change the documentation. You can't go back in time and add the temporal component or strengthen the physician narrative. You're stuck with what's in the record. This is why real-time clinical auditing is transforming hospice compliance. Instead of discovering documentation gaps after claims are submitted, what if your system could catch these issues while your clinician is writing the note? That's exactly what Hospice Intelligence does. Our platform works in real time, flagging missing LCD criteria as nurses document their assessments. If you're documenting a coma patient and haven't addressed the 3-day findings, the system alerts you immediately. The difference is dramatic. Instead of a denial letter 6 months later, your clinician gets immediate feedback. This note needs specific neurological findings to support coma criteria or add causation language connecting the pressure ulcer for immobility from coma. They can fix it right then and there while the patient interaction is fresh in their mind before the note is finalized. So let's take a moment to talk about what this means financially. A denied claim for a 90-day certification period can cost your agency over $20,000. If you're selected for a TPE audit, they'll review 20 to 40 claims. But the real cost isn't the denied claims. It's the staff time spent on appeals. Nurses, physicians, compliance officers, sometimes attorneys, all trying to reconstruct documentation months after the fact. And if patterns of deficiencies emerge, you're looking at prepayment review that devastates cash flow, potential UPIC investigation, inclusion in the special focus program, or even exclusion from Medicare. Compare that to the cost of prevention. Real-time auditing catches issues at the point of care before they become denials. You're protecting your revenue, your reputation, and the ability to serve patients. Medicare audit activity isn't slowing down. The agencies that thrive in this environment are the ones that build compliance into their daily workflows instead of treating it as an afterthought. If you want to protect your agency while empowering your clinicians to document with confidence, Hospice Intelligence can help. Our real-time audit platform ensures every note meets LCD requirements before it's finalized. Don't wait for an audit notification to discover gaps in your documentation. Visit our website to schedule a demonstration or reach out to our team for a personalized consultation. Your patients deserve excellent care. Your agency deserves protection from preventable denials. Hospice Intelligence delivers both.